Hello everyone, I am ARMAANDEEP Singh, resident in radiology at KEM, and in this series of interviews with eminent GSites under the chair of M.B.B.S. sir and Medical Humanities Division, it is my honor and privilege to invite our former Dean, HOD of Radiology and my guide, Dr. Hemant Deshmukh sir, for this interview. Welcome sir.
Thank you.
Sir, as you may have seen these series of interviews, we try to look at the sides of the GS site which are less often seen. A site outside the office may be a casual one. So my first question would be, please tell us about your childhood, your background, the values that affected you.
You are taking me back, 60 years or maybe 55 years in my life, and there is always a first chapter to start with, and when we start to read the first chapter of your life, definitely a lot of memories come forth. The earliest memories that I have about a doctor or even my childhood are going to the school as maybe somewhere around 5 to 6 years of age. There was a new school which was built in those days in Bandra East, and that was a Christian missionary school which was called as Cardinal Gracious High School, and that started somewhere in the year 1962, and I took admission in this school somewhere in the year 1965 as a kindergarten student. And when I started going to the school, this language, which is English and my mother tongue being Marathi, wanted a lot of changes in the way that I speak, interact with fellow students and my teachers during the school days, and obviously whosoever came in front of my path. And this huge change from a mother tongue to a new language, which is English, was definitely a turning leaf in my life, and that was the start of my education in 1965 till 1975.
Okay. Sir, as you said, you were in Bandra East. How did the culture of Mumbai in those days affect you as a childhood compared to what you see today? How was it different back then?
Everybody knows that a city grows with the people getting added day in and day out. There's a lot of migration happening in the city of Mumbai, even during 1950s, 1960s, 1970s, and over a period of say 2 decades, I have seen a remarkable change in the landscape that I grew in Bandra East. And that landscape, if you remember or if you have seen old pictures of Bombay, you will see that there were no multiple skyscrapers in those days. What we had were just ground plus 3 story structures, and these were enough to keep us glued to the sky all the time. And this vision of going higher up beyond 4 floors of your life, I think plays a profound impact on your mind all the time. And this landscape of a large canvas where people kept on adding themselves, people kept on migrating to the cities from the villages, and even my father migrated from Andhra Pradesh to Maharashtra in the year 1960, and what we saw was a close culture of people staying together all the time. It was called a colony, which simply meant that people of diverse cultures were united those days. Christians, Muslims, Hindus, Sikhs, everybody stayed together all the time. There were no different buildings for each community, but everybody grew together, everybody went into each other's houses, and that's how we came to know about each other's culture, and we started loving each other during those days itself.
Sir, and through this, when you were growing in those days, how was the culture of medicine and how did medicine come into your life and how did you come into this path? Because there was no NEET, maybe there was no counseling, there was no aptitude test. So how did you choose medicine?
When I finished my schooling, the only other alternative those days was going to a science college, becoming an engineer or becoming a science student. And there was no other option. If you get less marks, you go into commerce. If you still get lesser marks, you go into arts. And that's how I went into science. Average student those days. In the 10 years of my schooling, I remember I secured only once the first rank in my school, and probably I think the students were competitive, and I didn't really bother about getting the first rank all the time in each year of schooling. And when I joined the science college, again the whole idea was to either become an engineer or become a doctor. And since none of my family members had a doctor in the family, I thought, why not try medicine as a career, because the only other student that I saw in my locality was Dr. Avinash, and he was my next door neighbor. And I in fact asked him whether I should take medicine, because he was already admitted to GS Medical College somewhere in the year 1974, and we were still school students those days. And he said, if you get good marks, you come to GS Medical College, and if you're serious, come to GS Medical College. These two words changed my entire focus towards education. And if Dr. Avinash Supe can join, I think we should make efforts to see to it that I also come to the same college that my friend is studying. And that's how I think I got to know GS Medical College. Life beyond Bandra East was none. Parel was probably the first suburb, or probably the first station that I encountered after 17 years of my life in Bandra East.
Okay. And sir, another thing is that the composition of students in your undergraduate batch, if we see in those days, GS was only for Mumbai maybe students, essentially, more or less. There was few overseas students, some outside students, but essentially it was a Mumbai culture in GS. Currently we see that people all over the India, especially rest of the Maharashtra, are getting into GS. So how is the culture different from what we see today in the GS sites?
There was always a fierce competition between medical students admitted in GS Medical College and the rest of the medical college. In fact, the identity of GS Medical College was such that if you get admission to JJ Hospital, it was not considered medicine. Even Sine and Nair were not considered as an option. That was a natural bypass of, if you get good marks, you land up in GS Medical College, and if you don't get so good marks, I think you land up in Sine Hospital or Nair Hospital. But I think the competition was very tough. Even inter-science, which my seniors were in, I remember that in 12th standard that I secured certain marks, and those were, according to these days, were not very high marks. We were not very bright students as such, but the will to do something in life, I think that changes the entire course of someone's life. Taking up medicine, it's not the number of marks that decides whether you take medicine or you become a surgeon or you become a radiologist or you become an engineer. I think you need to have a lot of passion, you need to have a will to compete in life, to become what you want to become. And unless you are passionate, unless you dream about what you want to become, I think nobody can get into engineering or nobody can get into medicine.
Definitely, sir. That is something which you have highlighted very correctly. Moving on, sir, I would like to ask you, what were your most cherished memories during your undergraduate days? Like we have in the second year, the trip towards the north, or maybe the events. So what were your most cherished memories?
My batch was called as Raj Narayan batch. That was a supernumerary batch amongst everybody. So we were special kids in the entire GS Medical College history, and we coexisted with 6 months senior to our batch and 6 months junior to our batch. So in 1 year we had 3 batches taking admission into GS Medical College, and being a smaller batch than the other senior and junior batches, I think we had a very special place in GS Medical College. And as undergraduate students, the competition was not very fierce. I still remember people, hardly 1 or 2 students coming with wearing trousers made of jeans. Otherwise, most of them were wearing trousers made of either woolen or cotton pants. And it was very rare to see people wearing jeans. I think that was a big cultural shock to most of the undergraduate students, that they used to always label somebody coming with a jeans trouser as a foreigner, because these jeans trousers were always imported from either US or UK, and anybody who had access to jeans was always in inverted commas said to be a very high profile family in the city of Mumbai.
Okay. Sir, now we see that even just after taking admission, maybe after a year or two, the students start thinking about what to do after 5 years. So they try to prepare about the hurdle that they have to cross of NEET. But in your case, you have mentioned in your earlier interview that you were getting OBGY based on the whatever scheme was there to allot specialties, but you wanted radiology, which was an odd choice for that time. So how did you make that choice, and what influenced you?
There are 2 things which I learnt in life. Always make good decisions and always walk away from bad decisions. So these are the 2 things that almost shaped my choice to become an interventional radiologist. And getting into obstetric and gynec was probably those days not so good for a male doctor. And the whole idea of taking up obstetric and gynec was to have a surgeon's feel, because general surgery was the obvious choice for a person who takes up surgery. But the next best surgical field was always obstetric and gynec. And the feeling that everybody gets to choose one's passion was either to become a physician or to become a surgeon. So if you have a surgical mind, take up any surgical field. If you have an intellectual mind, always take up something which is related to a physician. Somebody told me that one of my friends said that he is in need of gynec, and if I leave gynec, he gets to do gynecology. And that's how these seat swap happened those days. And just because I left gynec, the other person could get gynecology, and he made his career in gynecology for the last 30 years. And the only other option that was left to me was obviously radiology. And though radiology was not a surgical field, but I always had an inclination to do some kind of surgical work in radiology, and that's interventional radiology.
Wow, sir. And I also would like to acknowledge the fact that this was the time when there were advancements happening in the field of interventions in radiology. So sir, taking on that and comparing it with Indian scenario, how did interventional radiology develop at KEM?
Interventional radiology, I think the 2 stalwarts that I remember in interventional radiology is Dr. Dara Kuka and Dr. Malini Nadkarni. And when I was a postgraduate student in radiology, both these stalwarts were not there in the department of radiology. But their prodigy, Dr. Ravi Ramakantan, was a passionate interventional radiologist. He was juggling almost each subspecialty of radiology. We never had something which is called as CT scan or CAT scan those days. We never had magnetic resonance imaging. So the only other option in radiology was general radiology, and in KEM radiology it was always interventional radiology. And when I say interventional radiology, it just meant that you do a diagnostic angiogram, and it is about poking the blood vessels, it is about poking the organs in the body, and some kind of interventional radiology which would help treat a patient were the only two procedures that I vividly remember. That is percutaneous biliary drainage and percutaneous nephrostomy. So the clinical goal in these two procedures was to relieve obstruction, and you can imagine the joy that an intervention radiology gets when he sees a spurt of bile or when he sees a spurt of urine coming from an obstructed side, and this side is so gratifying that the whole idea about helping a patient overcome his obstacles is the most choicest field that you can choose.
Sir, talking about obstacles, we see that when Charles' daughter was doing this, he faced great objections. Even the requisitions were written, visualize, do not try to fix. So how was the scenario when you were doing it? Was it easier to convince your colleagues how to get patients, convince patients? How did things work back then?
There were two things which Ravi used to always tell me. Make the clinician dependent on the radiologist. So if you address the clinician's problem, I think there itself lies the success of intervention radiology. So unless you address the clinician's problem to overcome the patient's grief, I think you are 10 times ahead of a clinician to treat his disease rather than actually opening up the patient and not treating the patient. So this was a stage where it was a minimal access surgery, it was a keyhole surgery. The only armamentarium that we had was needles and some kind of tubes, and needles played a major role in actually relieving all kinds of obstruction. Diagnostic radiology, something like what we call as diagnostic angiography or diagnostic venography, those days was in demand because there was no cross-sectional imaging available for the clinician. So any clinical problem unresolved, undiagnosed, I think angiography was supposed to be an exploratory angiogram, something akin to an exploratory laparotomy. So if you don't find answers to a clinical problem, I think angiography served as the most easy problem solving department in KEM hospital. Intervention radiology did not exist in any of the other hospitals in the city of Mumbai or in the state of Maharashtra, and we could count certain centers in the northern part of India, that is Delhi, and in south, either in Bangalore or Kerala, where sporadic intervention radiology was being practiced all the time.
Sir, now you have been at KEM since almost 1986. You had a brief stint in TNMC, but then again you joined back and you were always there. So how would you describe these association with BMC, and how was it different from what happens outside over the years? You must have seen private hospitals growing up. How is it in interventional radiology?
The time that I chose to pick up intervention radiology, I think I was the longest serving intervention radiologist in GS Medical College. I have been practicing intervention since the last almost more than 35 years, and not really being away from intervention radiology when I was in TNMC. But even in TNMC, as the head of radiology for almost 2 years, I tried to develop the department there, tried to do a lot of venous intervention, and in fact the students who were very keen to learn intervention radiology in Nair Hospital benefited a lot during those days when I was in TNMC. And the public hospitals per se never had intervention radiology in the city of Mumbai. So the public hospitals wanted to set up intervention radiology in most of the other hospitals post 2000, but you can imagine the amount of interventional procedures that were done in KEM hospital between 1982 and 2000 were almost to the tune of 1000 procedures. But beyond 1998, I think the number of interventional procedures multiplied, they compounded in numbers, just for the sheer reason that the clinicians in KM were dependent on interventional radiology for a clinical problem, and interventional radiology always gave them the solution. A life-saving procedure saved a lot of lives in KM hospital. Minimally invasive access treated most of the terminal patients who were almost going to die because of exsanguination of blood, and embolization was the cornerstone of the interventional radiologist to become popular amongst the clinicians in Bombay.
Sir, another, this is a great point. Like, when you are a pioneer, you have very few people to look up to. Like today, people look up to you in this field and many others of your skills. But who did you look up to, and who were your inspirations? Maybe outside medicine. What were your thoughts inspired from?
The first time I thought of doing intervention was actually before doing radiology. I spent 1 year clinical posting. That is 3 years of MD radiology. I spent at least 15 months in clinical medicine. That was 6 months of general medicine, some months in infectious diseases hospital, few months in neonatology. And there, during the clinical medicine posting, I realized that patient needed treatment, patient needed invasive kind of treatment, and even in medicine, doing a pleural tab blindly without ultrasound guidance, or in fact doing ascitic tab, or in fact simply withdrawing cerebrospinal fluid from the spinal subarachnoid space was a great skill to have, and these skills can be modified as an intervention radiologist. And the only other time that I thought that I should take up intervention radiology was when I saw my colleagues struggling with puncturing a biliary radical to withdraw bile. That's the time when I wanted to step in happily and actually withdraw bile. And that first sight of bile spurting from an obstructed biliary system was so gratifying that I decided during those residency days that I should take, I will take, and I will continue practicing interventional radiology.
Yes, sir. Coming to the next phase of your journey, sir, you're the first radiologist who became Dean of the Institute. So, how did this idea of Deanship develop, and how did you make that decision of accepting it or going towards it?
Being an interventional radiologist, I think the mindset is such that you always try and resolve conflicts, you always try and resolve patient dilemmas, you always try and resolve the clinicians, the clinical problems all the time. And being a true GSI, I always had a lot of feelings about the place that I grew up with, and the feelings that I grew up in this segment of Parade, staying there all the time right from undergraduate days, and I thought why not develop this hospital, though it is very difficult. That I realize it later on, that unless everybody works for the development of the institution, the institution doesn't develop. The institution cannot develop just because one man is wanting it to develop. And this feel of developing an institution and seeing to it that if you can make a difference to this institution, I think more people will like this institution. And over a period of time, what we have realized is the influx of non-Bombayites in GS Medical College. They just come with the sense of studying and not with the sense of belonging to GS Medical College. And this makes a big difference to the development of an institution. So the faculty, if you are with the faculty, if you are with your colleagues, I think this institution will definitely be able to see a century happening in 25-26.
Sir, looking at your illustrious career in the hindsight, what do you think was the crucial points that challenged you, but at the same time when you overcame them, they taught you lessons that you remember for the rest of your life? So could you please point out few instances where you really thought that, okay, this is something new which has encountered and you need to think outside of the box and then make changes? which will impact you for rest of your life. Any powerful impacts during your tenure, maybe during the deanship or during your career as a professional? Did you encounter a patient that taught you more than any book could, or something that could inspire people who are listening to you?
No, two things which I learned over a period of time is believe your instincts, and your instincts are going to solve life's biggest problems all the time. And unless you are in tune with your surroundings or with the universe, new ideas will never be able to be implemented in either your own personal life or in the working of the institution at large. So what we have learned over the last so many years in GS Medical College was patients have a lot of problems, and you need to solve each patient problem all the time. And unless you have an autopilot mode where the entire institution works, developing the department as a faculty chooses to develop is not the way to go forward, but it has to be a cumulative idea, it has to be a cumulative effort, it has to be an idea which probably 100 other colleagues should comply with, and 100 other colleagues will help you to have a stronger hand to change the way that you are working in the city of Mumbai. And patients who have come to KM or who have come to intervention radiology have taught us to think out of the box all the time. And I vividly remember one time when I and Dr. Kranti Kumar Rathod, who were routinely doing interventional procedures, routinely treating mesenteric angina with angioplasty of the superior mesenteric artery, we both looked at each other and we both laughed at each other. And probably that was the time when we realized that we were both thinking the same idea that each of us was thinking, and that was why not develop a superior mesenteric artery stenosis in an obese patient so that he loses weight, when angioplasty of superior mesenteric artery itself will put on or will add weight to the patient's body. And this idea made us think that you can actually, in a beneficial way, develop a stenosis in a blood vessel to reduce the blood flow and treat a disease. So that was the biggest idea that we two of us came out with, and probably that was the idea, probably the patient taught us this idea, and we are in the process of developing a medical device wherein we are going to treat obesity with a minimally invasive blood reduction stent.
Yes, sir. We all know and are proud of that patent. Sir, what is your vision for the upcoming centenary celebrations?
COVID.
Sir, as you know, we have just come out of the third wave of the COVID pandemic. How was your first response? Like, you are the head of an institute that took care of a huge population. So what was your first response? We know that a task force was developed, but how it all happened? Like, what was the first response to such a calamity?
There were two meetings which were held somewhere in December 2019. I remember that there were stray cases of COVID happening in China, and we were really not bothered. But a lot of physicians were trying to tell us that this COVID is probably a very highly infectious disease and this may spread to the entire world. And I remember in January 2020, the Honorable Chief Minister had a meeting in Bandra West, and that was the time when it hit me that if a politician is thinking, if the current Chief Minister is taking a meeting to take stock of what is going to happen in the city of Mumbai, I think that was the turning point. And in March 2020, we realized that we need to act very swiftly, we need to act very fast. And the then Commissioner of MCGM, that is Mr. Praveen Pardeshi, took a marathon meeting in the first week of March, and that was the turning point that this is going to be a very serious affair. This is going to be a task which needs a lot of planning, and that was the time that a lot of minds started working how to actually implement preventive measures. And the only preventive measures for a pandemic of this magnitude was to just seal borders of all the countries. And then at a micromanagement level, it appeared that we need to seal borders of the cities, we need to seal borders of the state. And then actually what happened in the last week of March 2020 was a full blown pandemic which was about to happen in the city of Mumbai. And who else but the health authorities of MCGM were in full swing to see to it that the impact of the disease is minimized all the time, to see to it that we do start testing of patients suspected to have COVID-19, and obviously to isolate most of these patients and to quarantine people who are coming from this pandemic zone. So basically there were two things which were involved in this. One was isolation of patients or suspects, and the other was actually doing away with patients who tested positive for COVID-19 and isolate them in specific wards. Now the entire machinery, the entire brainstorming happened. A team of multi-specialists came into picture. I actually drafted and formed a team of people who were actively wanting to help in this pandemic. They included a lot of microbiologists, they included a lot of infectious diseases specialists, those days we had, and these were the specialists who qualified themselves as DM infectious diseases specialists in GS Medical College. We needed to have a lot of tracking of patients, we needed to have a lot of tracing of patients, and here we had the help of the preventive and social medicine department, and a full-fledged task force locally was formed to tackle any eventualities which would have affected the health of the citizens of Mumbai. And over a period of 3 months we realized that we needed to act swiftly and scale up the entire the startup facility that we had, and from a single ward to multiple wards, that is extending up to 500 patients. We divided most of these patients, we divided small teams which had a lot of like-minded people within them, and the task force saw to it that the resident doctors, not necessarily from general medicine but people from all walks of specialties like general surgeons, orthopedic surgeons, pediatricians, microbiologists, pharmacologists and preventive social medicine came together to see to it that they take up each subsection of the pandemic and see to it that the impact of the pandemic is minimized, and most of the patients who were fearing to come to KEM, the fear was addressed in the form of reaching out to them on landline, and that's how I think we could achieve a lot of success in treating patients in KEM. And most of these patients, mind you, were critical patients, not the mild, not the moderate, but only critical patients. And those were the days when we actually started setting up field hospital for patients with mild or no symptoms at all.
Definitely, sir. And this magnitude of response that KEM took up even outside the campus to various centers, our residents were working, even the call centers to take care of people whose relatives are admitted. It is a move that we could not have foreseen, and it is something that the generations will remember. Sir, what is your vision now for the centenary celebrations? Institute will be completing 100 years in 2026.
The planning already started somewhere in the year 2020, taking a 5 to 6 year span of preparations. A central team of like-minded representatives of each batch. I presume now there would be 100 batches, but all 100 batches are not alive right now. Whosoever represents each year of MBBS has been assigned to contact each friend of his and try and get a database of people who are right now interested in seeing to it that their alma mater completes 100 successful years of existence in the city of Mumbai. And there's nothing more that you can do. You can't have a twin GS medical college. You can always have a GS medical annex. You can always have a KM hospital annex. The number of patients and the number of students has grown manifold since 1925. Right now we have 250 undergraduate students, and this forms the basis of all the celebrations that would happen in 2026, that is completing 100 years of GS Medical College. Getting to know, getting to touch base each MBBS student who has graduated from GS Medical College is a humongous task, and all batch representatives are actively involved in seeing to it that the database is ready, reach out to as many people as possible and create a monument inside KM Hospital and label it as Centenary Tower or a Center of Excellence. It all depends on what contributions the GS sites who have graduated from GS Medical College come forward with. The other brilliant idea would be to see to it that we get a corpus of funds for the internal research and development of GS Medical College faculty. The basic idea about a medical college is not only educating students or not only treating patients, but the research and development, which is so much lacking in most of the medical colleges in Mumbai or in the city of Mumbai. I think we should strive to see to it that a center of excellence for research and development is made. Ideation center is made. Something which MBBS student wants to develop an idea and see to it that he makes a fruitful change. The way a disease is treated can be nurtured, can be cultivated, can be actually see the light of the day in years to come, and that should be the focus in 2026. And all the funds that are required to have a center of excellence for research and development can only happen if the alumni contribute wholeheartedly towards the centenary.
Sir, on a lighter note, if you are not treating patients, where would you be? Or what would we find you doing if you are not treating patients?
I think a time has come when whatever 25, 35, 30 years of your teaching career, you have taught a lot of people, you have cultivated good interventional radiologists, you have shown them a lot of good work that can be done ahead in life. So it's always a comma, not a full stop to what you want to do in life, but it's always compounding. One person teaching 10 students, 10 student teaching another 10 student. So the transfer of knowledge or the transfer of skill happens, and it gets compounded to a larger extent over a period of time. My skills are definitely being transferred to my students. My students would be much better than me probably in the years to come. They will have new ideas, their skill may be far more superior than my skill sets, and I would always want to see that these students should treat patients like we treated patients. And it's not that if I stop treating patients, patients will always get better medical care from the students that we have taught. And it's always a dream to see the students teaching what you always wanted to do in life.
Right, sir. There will be a lot of students who will acknowledge this. And sir, I've heard your collar tune has not been changed for years. The banana boat collar tune. Are you? Is it a deliberate attempt to keep it same, and what is so special about it? This is a question many people want to know.
Yeah, I think somewhere in 1994 or 1993, there was this culture of landline, and suddenly the Indian economy just opened up, and we had a lot of pagers with us. If you remember, we had pagers, and then you just had to dial that pager, and the person from the other side would call you back on a landline. And after the pager, I think the mobile revolution came somewhere in 1998, and I was the first mobile owner in the hospital, and I could remember that because no other person in KM had a mobile those days, where the charges for 1 minute, the airtime for 1 minute was something to the tune of 16 rupees for 1 minute. And if you get a call, you pay 16 rupees if you speak for a minute. And it was initially used as a pager. You just see the caller number and then dial from the landline. Then I realized that you need to have a unique identity to yourself, and that was the time when the caller tunes came into picture. And this was a Banana Boat song which I heard long time back, and that was readily available. The mobile provider or the mobile caller tune was a gift from the mobile provider, and that's how I like that song. I like that caller tune, and I never wanted to change it, because changing a caller tune is what tells about the personality of the person owning the mobile, or the actual uniqueness, or maybe it's a stamp of the person who is actually having the caller tune, and I don't want to change my identity of that.
Definitely, sir. Definitely, sir. Anything else that I may not have asked you would like to add, or anything you would like to tell to your viewers? Most of them would be looking up to you.
Not really, because once you stop teaching, I think people stop asking you a lot of questions, and that's the time when you question yourself, try and answer those questions yourself, and always be helpful to others all the time, and that's what the patient needs all the time. He doesn't want Dr. Hemant Deshmukh or Dr. ARMAANDEEP, but he wants a doctor. The name really does not matter to him. He just wants a helping hand in any form that anybody wants to help him save his life. I think we should be helpful all the time in life.
Thank you so much, sir.
Thank you.
So I would like to thank sir once again for coming today with us, and I would like to thank Loka Mehta ma'am for giving me this opportunity to interview sir and the Division of Medical Humanities. Thank you so much for viewing.
Thank you, Arman. It was my pleasure to be here on this occasion, and I'm looking forward to the centenary year. Any meaningful contribution from my side, I think I'm most willing to offer, and our passion to develop an institution should always remain in your heart. Thank you so much.
Thank you, sir.